Welcome, everybody, to another Spark Study Club podcast. It's great to have you here, and I am really excited to introduce our guest tonight. It's Dr. Anthony Urbanek, oral surgeon, among many other things. Some would say the most interesting man in dentistry, and somebody that I consider to be a good, close personal friend. So, Dr. Urbanek, thank you for joining us on this podcast.
Are you welcome, Donovan? I am really pleased to be here.
So the reason we're meeting today is to talk about your upcoming webinar with Spark Study Club. That's on May 14th at 7 p.m. Eastern. And the topic of that webinar is going to be on temporomandibular disorder, joint disorder. And I know this is a topic that has confounded the dental industry for decades. And you've had some really exciting discoveries that you're going to share along with the science behind it on that webinar. But before we get into it, I thought it would be helpful for our listeners to just get to know you a little bit. And I say most interesting man in dentistry, tongue in cheek, but not really joking all that much. And we could do a whole podcast just on your bio, but just a couple of highlights. Obviously, in addition to being an oral surgeon, medical doctor, you've got a PhD in anatomy and cell biology. You're a private pilot, and you serve as an aviation medical examiner, which you're the only one of those I've ever met. You run successful medical clinics in Haiti and Jamaica, and so many more things. And I just think it's really interesting that after 30 years of as an oral surgeon treating TMD and getting inconsistent results, you decided to pivot and go against the grain a little bit. So as I said, we're going to get into that, but first, it's been such an incredibly diverse career, from fetal surgery research to founding those medical clinics in Haiti and Jamaica. But if we take a step all the way back, what originally drew you into the field of oral and maxillofacial surgery?
Well, I was in dental school. I went to dental school. I chose dentistry because my older brother is a dentist. He's 8 years ahead of me, and everybody thought my older brother was very successful. So when I finished college, it was kind of a no-brainer that I wanted to be successful too. So I went to dental school, and make a long story short, I really fell in love with the basic sciences. I didn't enjoy or appreciate college very much because they were teaching me things I could never use. When I went to dental school and I began the what most dental students call the arduous 2-year program in the basic sciences, I found it extremely interesting, and I did very well at it. And from that, once I got into the clinics, I decided pretty early that I wanted to be an oral or maxillofacial surgeon. So, I really love the basic sciences, and I thought the basic sciences applied most to surgery. And then I kind of looked around at what kind of surgeon I'd wanted to be. And actually, I have to admit that I was on the cutting edge of maxillofacial surgery. Orthognathic surgery, temporomandibular joint surgery, microneural surgery, cleft palate surgery were non-existent when I finished dental school in 1973. And for a time, that's what I wanted to do. I felt I'd learned enough, I'd read enough that there were some newer technologies in these areas. And the oral surgeons throughout the country didn't practice those kinds of things. I actually went and had interviews with both the plastic surgery department at Indiana, where I went to dental school, and the ENT department, and pled my case that, I wanted to be a maxillofacial surgeon, reconstructive maxillofacial surgeon. They just blew me off because they never heard of such a thing. And then about that time, I had heard that there were a couple programs in the United States that were just forming. One was at Harvard and one was at Vanderbilt, that offered the double degree, the addition of a medical degree, and that they were focused more on the newer cutting edges of maxillofacial surgery, orthognathic surgery, cleft palate, et cetera. And so I was put an application in, fortunate enough to be admitted into this program at Vanderbilt, where they taught me, those skills and the science behind the cutting edge, large kind of surgery that I spent most of my career in the operating room rather than in a dental clinic.
It's really interesting because as I look at your story and what led you to some of the findings you've found with TMD. It's all the common theme has been you taking this non-traditional route, both in your education and in your research. You've always kind of gone against the grain a little bit, and I'm curious what's motivated you to always challenge the status quo throughout your career.
Donovan, I honestly have to say I didn't intentionally try to challenge the status quo. In fact, when I was in dental school, my mantra was keep my head down and my mouth shut, just work. And so I don't want anybody to believe that or think that I was out there trying to challenge anybody. I always did think outside the box. When I was a kid, I used to love to fix things, and you just have the resources available. Whatever the resources are, and you research education or money or contacts. But I began to look at problems as an opportunity to fix something. So I always focused not on the problem itself, but the opportunity to use that problem to create something. Okay. So regarding maxillofacial surgery, we know a lot of people had funny looking faces, and from that came the science of orthognathic surgery, and people had problems with the nerve innervation of the face and related structures, and from that came the science and technology of microneural reconstruction. And so, first of all, you see the problem and then try to find a solution for the problem. So I really didn't. But when you do that, here's the answer to your question. When you do that, you automatically cut across the grain of the status quo. The status quo is by definition the status quo. This is the way we do it. We've always done it this way. This is the way you're going to do it. And they don't look at the problem solving nature of science and the professions, et cetera. Certainly, most dental students, medical students, they come into the program thinking, well, all the solutions are already there. I just need to learn them, right? Well, both in my education in dentistry and the basic sciences and the academic sciences and in medicine, as I went through that, I began to observe problems that have not been solved. Obviously, there were things that came across my path that I went, well, this is what they say to do, or this is what everybody does, but it really didn't solve the problem. So I didn't intentionally ever try to go across the grain or to contradict the status quo. It just worked out that when I did my thing, it automatically did that, and it filtered into all of aspects of my life, not my academic life, but when I started programs in third world countries or in certain parts of my aviation career, I bumped up against the same thing. It's just like you're looking to solve a problem, you're automatically going to cut across the status quo. When it came to TMD, that was a huge obvious. That was a problem that was obviously not solved.
Yeah, well, let's talk about that. So, I think it's safe to say that a lot of our listeners, dentists, feel overwhelmed um, with the whole subject of TMD, diagnosing and treating it. And so, right off the bat, what do you think are the biggest misconceptions that keep them from addressing it effectively or having more confidence in addressing it?
Well, the first one is what all the dentists, and I mean all the dentists were taught in dental school, myself included, and that is this joint that we call the temporomandibular joint is different than any other joint in the body. And I've never talked to or met a dentist who didn't agree with that statement. Everyone is taught that this joint that we call the TMJ is different. Well, as it works out, this joint is no different than any other joint in the body. It has a little different anatomy. It's certainly located in a different place in the body, but it operates under the same mechanisms that any other joint. And that was obvious to me in my training in anatomy, cell biology, medicine, and dentistry. After a while, that this joint's no different than any other joint. So that's number one, that this joint is promoted as different. So, and it's complicated. They also promote it as very complicated. Why? Because it has a complicated name. It's categorized as a gangliomo-arthrodial joint, which every dentist is taught to say, right? Because why are they taught that? Because that's one of the questions on the national board. Every national board has the question, what's the category of the temporomandibular joint? So it's a complicated name, so it must be, doctor, a complicated joint. Well, that's just doesn't, it's not true. So it's not a complicated joint. And once you get into the basics of understanding how all joints work, then it really became apparent how to find what to look for when it comes to solving the problem of the conundrum, the enigma of what we've experienced for the past 70 years and trying to solve really what's going on, what's the real pathophysiology of joint problems. And and so when I decided after 36 years of working within the system, within the status quo of surgery on the temporomandibular joint, and finding that a third of my patients that I operated on would be back within a year or two with the same symptoms. I had a weekend sabbatical with myself, thinking about how can I confront my patients and honestly tell them that I'm going to fix them when I know a third of my patients are going to be back within a year or two with the same symptoms. So I decided to give up temporomandibular joint surgery. I have plenty of other things to keep me busy, the other kinds of surgery I did. But when I decided to give up surgery itself as the solution for TMD, uh, with my research background, I decided to take a look at and see if I could figure out what nobody could figure out about this, obviously, what they think is a complicated conundrum.
Yeah. So I think without giving too much away, do you want to just share a little bit about the findings that you had and what the results have been?
Well, I really gave the most of it I already gave to you because this joint is no different than any other joint. And if you get
Right.
into literature, if you read a few articles, you learn how all the joints work. And when you apply that information to the temporomandibular joint, it begins the light comes to view and you begin to see what's going on. But I'll explain it further in our webinar. I'll be happy to, but let me just say this, and this is kind of maybe the incentive to come and watch the rest of it. Tennis elbow and TMD are the same disease, just different joints. And if you know how tennis elbow operates, what that disease is, then it will explain exactly what wasn't known about TMD and that now we know and I can explain in great detail.
So why do you think that right there is such a controversial statement? Because it seems so simple to me. I'm not a dentist, I'm not a medical professional, but when you explain it like that, as somebody who's known plenty of people who had TMD, it just makes sense. But yet there's a lot of pushback on that way of thinking. So tell me, what's your perspective on that?
Well, I think that comes with the definition of what the status quo is. The status quo is everyone has biases, whether you're a general dentist, you're an orthodontist, you're an oral and maxillofacial surgeon, whether you're an ENT doctor, PCP, a neurologist, everyone has biases as to what they can do in the healthcare system. To summarize, if all that you have is a hammer, then everything looks like a nail. Now, hopefully that's meaningful to the people that are viewing our discussion here. Maybe I can define it or describe it if it's not already. In my mind, it's really clear. You know, as a surgeon, that's what I did. That was my ability as surgery. So viewing the problem of TMD, well, it must be a surgical problem, right?
Yeah.
I'm going to fix this surgically. And frankly, I admit, I never even stepped back until 14 years ago when I decided not to do any more surgery. I never stepped back and say, well, maybe, there's a totally different point of view on this, right? Maybe surgery, although my intentions were good and the other oral and maxillofacial surgeons' intentions were good, that the answer wouldn't be there. But when I finally decided that I couldn't confront my patients and honestly tell them that I was going to fix them, knowing that a third of the time they'd be back, and step back and took the time and made the effort to do my own independent research throughout the books, throughout the congresses, didn't listen to anybody else. I just went through the standard scientific method and the solution actually came to view extremely rapidly and extremely clearly and extremely fast.
Which we're going to talk about on May 14th. And I'm really looking forward to that conversation because I know the presentation material and I'm excited. I'm excited every time you go through it. But the other thing that I about fell out of my chair when you shared with me is the just how extensive this problem is in our country, I suppose our world. Can you talk a little bit about just how prevalent TMD is? Because I didn't realize it's so much more than just a clicking jaw.
Oh, for sure. Yeah, the articles or the information that you get in dental school or even specialty programs in dentistry, they usually refer to a bunch of articles both nationally and internationally that portray TMD symptoms, of prevalence of anywhere between 15 and 30%. And depending on the country and how they define it and what symptoms they include, um, it's usually between 15 and 30%. They're not bad articles. They're written pretty well by fairly scientific individuals. But what I found that those articles don't include is they don't include the majority, the other symptoms, which are not the majority, but a great number of tinnitus, ringing in the ears, subjective hearing loss, which is a feeling of fullness in the ears, like you can't clear your ear after swimming when you haven't been swimming, and vertigo, dizziness, and a new, a relatively new, actually brand new symptom that I uncovered, which is arm, hand, finger tingling and numbness, is absolutely directly responsible from temporomandibular joint problems, and I can explain that. I will explain that anatomically. But when you include those other symptoms and you include the symptoms of migraine headaches that are misdiagnosed constantly by my physician colleagues, and the tinnitus, subjective hearing loss, and vertigo that is constantly misdiagnosed by my ENT colleagues, that prevalence goes from 15 to 30% to 45%. 45% of females have temporomandibular joint symptoms when you include all of the symptoms. And clicking and noise is just one of the symptoms. Headache is the most prevalent of all the symptoms. And when you list out all the symptoms, and I prove this to myself, I do it kind of jokingly whenever I'm in a meeting or I'm in a group of people. If there's two or three females there, I ask them, "Do you have any of these symptoms?" And at least half the hands go up, um, with the symptoms of this problem. So it's very, very prevalent, and it is life changing in a negative way. That's what really keeps me in it. That's what keeps me in not finding the solution. We have the solution, and in getting others to help find and treat these folks, because the majority of patients that I continue to see on the day-to-day basis have been run around in circles by the professions. When I say professions, both medical and dental professions. And we have the majority of people we see have been run around in circles for decades. It is not unusual. In fact, most of our patients have a 10 to 20 to 30-year history of going from provider to provider to provider to provider, seeking relief of these symptoms and getting recommendations for whatever, pills, Botox, uh, physical therapy, all of them intended to treat symptoms, but none of them go and treat the cause, the common denominator. If you make the common denominator go away, all the symptoms go away magically.
Yeah. Well, you said a couple of things there that are really interesting. I hope the audience picked up on. Number one, TMD disproportionately affects the female population. And to such a degree, it's almost 1 out of 2 have some sort of symptom that could be tied back to TMD. And then the other was that the symptoms are so broad that misdiagnosis is probably the biggest problem. Is we're putting these women and men too on anti-migraine pills or whatever Botox, whatever it might be, without actually getting to the heart or the root cause. And so that's got to be exciting to you to at least be able to say that there's a better way. And it sounds like that's what's motivating you.
Absolutely. That's what
Yeah.
motivates me.
Yeah. That's great. So, well, before we wrap it up, just want to ask you to share with the audience what your ultimate goal is with sharing this research and teaching this course on May 14th. What do you hope attendees will walk away with?
Well, number one, a much better understanding or a complete understanding of TMD. It doesn't take, this is not a complicated disease. No, you're taught it's a complicated disease. It's not complicated. But my goal is to have as many other practitioners, dentists, general dentists, oral surgeons, orthodontists in the profession who tackle this problem as well as we do here in Middle Tennessee, and the other doctors who use our methods and materials and success with these patients. Our success rates are unbelievably high. When I tell you how high they are, immediately the skepticism is there. And you can have the skepticism, it's fine with me. But my goal, because we can't see all these patients out of Middle Tennessee. I mean, we I'll give, we have 900 referral sources in Middle Tennessee who send us TMD patients. Why do we have so many? Because we get the job done, because we actually have the solution. And we need other doctors throughout other areas of the country to do this, for sure.
Yeah. I think that's a great place to end it, Tony. I really appreciate your time today. Looking forward to a great course on May 14th. Again, for those who are as interested as I am in being there, just go to sparkstudyclub.com and there's a big banner right at the top of the page for you to click to register. And we will hopefully see you there. Dr. Urbanek, thank you for your time. And we'll talk to you soon.
Thank you, Donovan. I look forward to the 14th.
Okay. See you then.